Hello all, this is Dr. Dheeraj Masapu. I am a consultant neuroanesthesiologist, and in this video I would be talking about what anesthetic drugs I would be using when I am giving anesthesia for a brain surgery. So it will be quite interesting for you to know because when we anesthetize a brain surgery, the neurosurgeon would be operating on the brain and even our anesthetics act on the brain. So how do we titrate and how do we maintain a patient with brain surgery? So this video is mainly for two types of audience. If you're an anesthesia student, then I think I would be talking my practical experience when I'm choosing the drugs while anesthetizing a brain surgery. Or if you are non-medical professional, you would be knowing what anesthesia is, what anesthesia medications are we going to use during a surgery, because most of the non-medical people would be thinking that we would be giving some injection and patient will sleep. It is not so easy, I would be telling in this particular video. So you can see in this particular here the surgeon is actually operating, and that is the surgery which is going on in the brain, and he is Dr. Swarup Gopal, and he's a very good neurosurgeon. So that is where he's operating, and there is a device he's using that is called as a suction stimulator. I would be explaining about that in the end of the video. And this is how my anesthetics would be. So this is how I maintain my patients, and this is how I maintain my hemodynamics or BP and heart rate during the case. So how do I do this? So how do I choose the anesthetics? So what are the different anesthetics that are being used for a brain surgery? So number one, the choice would be to pre-medicate the patient. So when you pre-medicate the patient, you try to calm the patient. So that is where some centers they use midazolam and fentanyl. So midazolam is a drug which is a benzodiazepine, and it acts on the GABA receptor. So it calms the patient. So I sometimes use, but if there is a neuromonitoring involved, so according to theory we are not supposed to use. So in those kind of cases I would avoid midazolam. Okay, and the second and the most commonly used drug before giving the major anesthetics is fentanyl. So fentanyl is a drug which is an opioid. It mainly acts on a mu1 receptor. It's an opioid receptor. So what fentanyl does is it causes analgesia. So the pain of the patient will be decreased. Okay, so these are the two drugs which are used as a pre-medicants, and these are the drugs which we give to the patient when the patient comes into the operating room. So this calms the patient, and it decreases his anxiety levels, and also it gets the blood pressure and heart rate to a very calm level when we actually administer the anesthetics. So that is about the pre-medication part. So then let us go into the actual anesthetics. So what anesthetics are we going to use? So now the patient is calm but awake. So we need to use a very powerful anesthetic to induce the patient. So induction of the patient is nothing but taking the patient from awake state to a state of anesthesia where you can start the surgery and do endotracheal intubation, that is putting a small tube into your larynx. So basically, what are the different anesthetics which are being used in brain surgeries? One is propofol. So propofol is an anesthetic which acts on the GABA receptor. So basically GABA is inhibitory neurotransmitter. So when propofol is given, so GABA is being facilitated and the brain is going to get depressed. So that is how the propofol acts. So propofol, how do we give? So how we give is basically it can be given as a bolus, and the dose calculation will be based on the weight of the patient. So 1.5 to 2 mg per kg you can give a bolus. On an average between 70 to 100 milligrams, or in young adults up to 120 to 140 milligrams would be the dose. Okay, so that is one way of giving. The another way which we regularly do is the induction of the patient through TCI pumps. So TCI pump is nothing but R-gate controlled infusion pumps, where you set what microgram per ml of propofol level you desire to achieve in a particular patient. So it's an algorithm which is already developed on certain people. So we feed the data of the patient in that particular algorithm, and then we give an instruction to the particular machine that so this many micrograms per ml is my desired serum level of propofol. Then it will slowly induce. So if you have these kind of gadgets, you can go for the technique that would be more safer. If you don't have the gadgets, then you can give the propofol based on the body weight. So these are the two ways by which we induce the patient. So once the induction is done, and then in a brain surgery, our concerns would be different. So what happens here is the intracranial pressure comes into the play, and the second thing would be the brain relaxation during the surgery matters. So sometimes what happens is there would be a brain tumor within the center of the brain, and for the neurosurgeon to reach that particular brain tumor, he needs a very lax brain or a very relaxed brain. So in that kind of situations, the anesthetics that you are using should have few unique qualities. So here the difference comes between two different types of anesthetics. So one set of anesthetics would be the inhalation anesthetics. They are the sevoflurane, desflurane, and previously isoflurane was used, but now commonly sevoflurane and desflurane are the anesthetics that are being used. So these are volatile agents. So these are a liquid which is converted to a gaseous form, and it will go into the patient through the tube which is in the mouth. So these anesthetics are very commonly used in non-neurosurgical cases. Even neurosurgical cases many people use, but in certain situations where we desire a relaxed brain, these anesthetics can increase the cerebral blood flow, because the inhalational anesthetics can have a direct vasodilatory action on the brain, which is mediated by nitric oxide. So what happens is when vasodilatation happens and cerebral blood flow increases, there is a possibility of brain being very tense during the surgery, which will not be favoring the neurosurgeon to reach the tumor. So but according to theory, this happens in a higher MAC. Usually bit above 0.8 to 1 MAC, the cerebral blood flow increase would happen. So if you are maintaining the patient in a MAC which is around 0.4 to 0.5, then this wouldn't happen. But what happens is during the surgery, you need to maintain a MAC of above 0.8 to 1, so that patient wouldn't be aware during the surgery. So to maintain such a MAC and to get a relaxed brain would be a challenge. So what we do is we maintain the patients on propofol infusions. So why we choose propofol infusions is propofol has a feature, the action of propofol on cerebral blood flow is exactly opposite to inhalation anesthetics. So what propofol does is it directly doesn't decrease the cerebral blood flow, but it decreases the cerebral metabolic rate. The brain activity is decreased. So what happens is when brain activity decreases, there is something called as neurovascular coupling. So when cerebral metabolic rate decreases, cerebral blood flow also decreases. So that is how brain operates. And when that happens, the cerebral blood flow also decreases and brain becomes very lax. So that is what a neurosurgeon wants during the surgery. So using propofol for the maintenance during the surgery is a very good option, and I personally have seen many cases having a very good operating conditions with propofol infusions during the surgery. So when you're giving propofol during the surgery, there are different ways of administering. So some people use regular infusion pumps to be administered. They calculate the infusion dose of propofol with certain regimens called as Bristol regimen and other regimens. So but now with the advanced technology, we have something called as target controlled infusion pumps, which I explained a little bit in the beginning of the video, where we set a desired level in the machine and we maintain it. So around between 3 to 4 micrograms per ml would be a very ideal target for giving propofol during the surgery. So the propofol will keep going and the patient will be sleeping, and surgeon will have a very good operating conditions. So this is about one set of medications. So now till now what we discussed is only about the hypnosis component, that is sleeping of the patient. But along with that, you also need to paralyze his muscles. Okay, otherwise there is every possibility of patient moving during the surgery, which will be very fatal in neurosurgery. For that, we need to give muscle relaxants. So muscle relaxants, what regularly are being used is vecuronium, atracurium, and cisatracurium. So cisatracurium is what I would be using, and many people use atracurium. So then these muscle relaxants, usually some people run as infusions, and some people calculate a particular time and they would be giving in a particular time dose slots. Around 15 to 20 minute time recording will be there, and the atracurium or cisatracurium would be given. And another component that you need to maintain during the neurosurgical cases is the pain or nociception. So how to do that? So in developed countries, they have remifentanil. That is a very beautiful drug. In India, somehow it has not come, and it is going to come in few months, it seems. So we regularly use fentanyl and morphine. These are the two drugs which act on the mu receptors in the body, and they cause a strong analgesia. That means pain relief. So when you are anesthetizing a patient, you have to take care of the hypnosis, you have to take care of the muscle relaxation, and the third component is the pain relief, which is taken care by fentanyl and morphine. So we will administer those medications also during the brain surgeries. So these are the different medications that we use while maintaining the brain surgery. If we do like this, then the laxity of the brain is maintained, and surgeon will have very comfortable operating conditions. Now let us come to the second part of brain surgery. Second part of the brain surgery is, in the initial part of the video I showed a kind of a black color probe that is called suction stimulator. So what happens is, when you're operating on the brain, there is every possibility that the very important structures in the brain getting damaged. How do you prevent that? So you prevent that by doing monitoring technique called as intraoperative neuromonitoring. So we have to use certain gadgets, and we stimulate at certain currents in certain parts of the brain and get certain waves. It is done by neurophysiologists within the operating room. To facilitate them, we need to modify our anesthesia technique into a different way, which I'm going to tell how usually it is being done. So if a neuromonitoring case is being done, and there the most important thing that you need to know is, you have to talk with the neurophysiologist and ask what is the waves that he is going to monitor. If he says he is going to monitor electromyography or motor evoked potentials or triggered EMG, then muscle relaxants shouldn't be used, because all the responses will be inhibited at the dorsal horn level and also in the neuromuscular junction. So in those situations, what we need to do is, we have to maintain the patients on propofol. Along with propofol, you need to add some adjuvant drugs if required. So most commonly the adjuvant drugs that are being used is remifentanil, fentanyl, dexmedetomidine, ketamine infusions. Okay, so propofol I already told you how I give. So how I choose the adjuvant drugs also I'll tell you. So many centers use remifentanil because it's a very short acting drug and very strong analgesic. But when you don't have that, then you have to go for fentanyl infusion. But the problem with fentanyl infusion is, over a period of time it accumulates in the body and recovery can get delayed. So that is the reason some people use dexmedetomidine, which has minimal effect on the neuromonitoring and a better recovery profile after long durations of surgeries, because neurosurgeries go for long durations. And nowadays ketamine maintenance also is coming up. So ketamine acts on the glutamate receptors, or NMDA. NMDA is one of the type of glutamate receptor, and by glutamate excitation, by glutamate activation, the electrophysiological waves are theoretically better with ketamine. So there are conflicting studies also which are saying that ketamine might not improve the amplitudes of certain motor evoked potentials, but theoretically ketamine would actually get you a better neuromonitoring waves. So addition of ketamine also is one way by which you can actually find a perfect adjuvant during the brain surgeries. So these are the different anesthetics that we use while giving anesthesia for brain surgeries. So then how do we administer all these drugs? So all the drugs would be going through the IV lines, intravenous lines. So, but the only difference is that the intravenous line that we are using when you're administering propofol should have the unidirectional valves, so that when they're going into the body, the backflow should not be there. So that is one very important precaution that you need to take. So this is about how we anesthetize brain surgery. And one more important thing is that the anesthetics, how they act and how they actually act on different parts of the brain, have been extensively studied. So, and then what they found is the frontal, the parietal and the thalamic areas are strongly inhibited by the anesthetics like propofol and thiopentone and other drugs. And also they study the EEG, that is the electrical activity of brain with different anesthetics, and they found that different anesthetics will have different kind of EEG patterns. So during the surgery we monitor something called as the depth of anesthesia. See, we monitor the EEG signals from the brain, and we try to make sure that patient is in the correct depth. Otherwise we will not know how much anesthetics we are using in that particular patient. So what we observe is older patients and patients with neurological diseases and patients with dementia, patients with Parkinson's. So these kind of problems when patients have, the requirement of anesthetics are very low. So in those patients, when I personally did EEG monitoring, the requirement is just 50 to 60% of a regular person. So there you need to use the EEG based monitors like BIS and entropy monitors. And now a new monitoring called patient state index is also coming up, which is very good. You can try using that. So when you monitor when you're doing a case with inhalation anesthetic, for example, even then you can use depth of anesthesia monitoring, and you can decrease the MAC if you're overdosing the patient. So depth of anesthesia monitoring I think should be used in whichever technique you're using, mainly in certain groups like a thyroid patient you're administering anesthesia, or a very old patients. So it will be very useful. It is not recommended in certain cases, but I feel it should be done. And particularly when you're not using muscle relaxants, there is every possibility that patient can move during the surgery. So that is a situation where you need to actually be more careful, and you have to use depth of anesthesia monitoring to monitor the patient. So, and along with this, another important thing that you need to maintain during the surgery is the patient's blood pressure, heart rate, temperature. So why are these important? I'll tell you. Because see, when a brain surgery is happening, if there is a decrease in the blood pressure, so body tries to increase the blood flow to the brain. Okay, the cerebral blood flow will increase. In the process, what happens is the brain can get tensed. And at the same time, if you're doing neurophysiological monitoring, when the blood pressure decreases, the waves wouldn't come well. So you should always maintain a good blood pressure. So maintaining a good blood pressure during the surgery is a key important element in brain surgeries. And maintaining a normal heart rate is very important, because in a higher heart rate, there is every possibility that patient can have a demand-supply mismatch in the myocardium. And temperature is I think every anesthetist now monitors the temperature. It's a very important aspect. So we use warmers inside the operating room, and so the warming blankets are used. And nowadays self-warming devices also are coming. I used, they're good. So these warmers actually maintain, you can set the temperature, how much temperature you really want, 32, 34, 40, 43. So you can set the temperature. So they will warm the patient. And usually we maintain a temperature between 35 to 36 in a patient. Less than 35 is not desirable. So above 37 is also not desirable. You have to maintain in that range. So if the temperature decreases, there are so many problems which can happen. One is the electrophysiological waves won't come during brain surgery, and the second thing is that the patient coagulation factors can get affected. The bleeding risk is very high, infection risk increases. So it's anesthetist responsibility to maintain the temperature during the surgery. So if I'm anesthetizing a neurosurgical patient, so these are the things I keep in my mind. And why I'm telling you is, so these are the tips and tricks that you need to follow. And if then if you ask me, so now you are told all these things, then anybody can do neuroanesthesia cases. It is not so. It is what I told you is just tip of the iceberg. The actual mountain is there below. Mountain is the experience. So how to titrate the anesthetics? The anesthetics are 3 to 4 only, but how you titrate them? Okay, how you actually give them in a right dose, and which decides the surgery and also decides the beauty of the recovery and outcome of the patient. So any change in the anesthetic regimen will be detrimental to the surgery and outcome of the patient. So that is how important the anesthesia is, and that is I think by listening to what I am telling you now, you would have got some idea about what anesthesia is and how actually we give anesthesia. So, and just to finish, I would like to tell some more things. The anesthetics also have neuroprotective properties. Okay, mainly the propofol and thiopentone are actually used as neuroprotectants also, even though the evidence is lacking, but theoretically they have a neuroprotective action. They protect the brain in the situations of any damage to the brain. So that is why sometimes we run anesthetics in the intensive care also. So when there is a head injury, if the GCS of the patient, that is the consciousness, we call it Glasgow Coma score, when the GCS is low and the patient is having a kind of hematoma inside the brain, or a subarachnoid hemorrhage secondary to aneurysm rupture, or a stroke patient comes. So those kind of situations, once the intervention is done, then we have to calm the patient and create neuroprotection, which decreases the intracranial pressure. And also these anesthetics have the potential to suppress the electrical activity, and seizure risk also will come down. So even though propofol has epileptogenic potential in lower doses, the doses at which we use usually suppress the seizure activity. So that is the advantage of using anesthetics in the intensive care, mainly the neurointensive care. So are there any problems with these anesthetics? If you ask me, there are certain problems. So if there is no problem, then anybody would give. So when you give it in higher doses, there will be a hemodynamic crash. That is, the blood pressure will fall down. So we have to give the anesthetics in a very calculated way. Only then the blood pressure of the patient would be maintained. So that there actually the depth of anesthesia monitoring plays a key role, I feel so. So when you know that this is the correct depth for the patient, then it would be very useful for the anesthetist in understanding what is the dose for that particular patient. So every patient is different, every physiology is different, and every PAC is different. Even though the anesthesia medications are the same, every case is different. So protocols and guidelines are there, okay, but what they are just to guide you, to give you a overall understanding. But once you reach a level where we operate, the super specialty level, it is more than following the protocols and guidelines. You have to individualize the care. You have to tailor it based on the patient. So a 90-year male coming for a surgery, the plan of anesthesia would be totally different from a 25-year male coming for a spine surgery. So even the protocols exist, you have to understand the physiology of the person. And how do we understand? By doing PAC, by doing investigations, by spending some time with him before the surgery, you understand. So that is how important anesthetist assesses a patient. So this is the reason maybe every day on an average anesthetist would be anesthetizing 3 to 4 cases. So 3 to 4 times they would be assessing people, how they respond to anesthetics, and they would be dealing any crisis in the OT. So that is why anesthetists gain knowledge in intensive care also. So any crisis management and those things would be learnt. So this is about the anesthetic drugs that we use in brain surgery, and I would do another video on anesthetic drugs for spine surgery in future, so that you get an idea about what anesthesia is. And if you people who like anesthesia would love these videos. Okay, so that's it, guys. And if you feel that it's an information overload It's not an overload. It is. I know I'm trying to educate people with anesthesia knowledge, so that the awareness should spread to people. Otherwise, many people are thinking that we give some medicine and patient will see. It is not so. It is very complicated than that, and there are so many layers of understanding. And after many years of experience, and I have come to a safe level of anesthetizing people. So any MD student will take an average of 5 to 7 years to reach a point where you can confidently deal majority of the cases. I never say that you can deal any case. That is not a right thing. So what I feel is, after at any experience, you should always be humble, and you should always have humility, and you should always treat every patient as your first patient, or you should always anticipate that something can go wrong while anesthetizing, and you should never be overconfident when you are giving anesthesia. It is more like a batsman's job. So batsman should respect every ball. Even one ball, if he's careless, he'll get out. So in the same way, anesthetist should respect each and every patient when he is anesthetizing. So that's it, guys, for today. I hope you guys like this video, and subscribe to the channel. If you want to connect with me, then my WhatsApp link is there in the description, and Instagram ID is masapudheeraj. You can connect with me directly. Many people are connecting with me regarding the choice of branches and whether anesthesia is a good thing, whether diploma is good or not, and some people are even asking thesis selection tips and those things. I'm trying to help them to the knowledge that I have, and I will keep trying to help you. And so we'll be doing some more informative videos in future in a very simple way, so that you understand actually what anesthesia is. Thank you, guys. Roger that.